to everyone. I have chosen today the respiratory system for my history and examination, so we can take it together as a system and discuss how we will approach this in a station of history as well as the clinical examination. Okay, so I hope you're all ready. Let's start. Okay. So actually, the points I will be discussing with you today is not only for respiratory system, it is for all the histories. If no matter what the station is, you should have set a number of goals for the end of your history station that you should be able to evaluate those points. Okay, so the first point is that while you're taking a history, you should be able to know which system is involved, whether it's the respiratory system, it's the GI. You should be able to know that. You should be able to find out in the history station while you're taking history. That's not only for exam, it's for every patient that you encounter. You should know which system of the child is involved in the disease process. The second goal is that which part of the system is involved. Okay, so suppose it's a respiratory system, you should be able to know if it is an upper respiratory, if it is a lower respiratory, if it is the ENT. So you should be able to know which part of the respiratory system. If it is a GI system, then you should be able to know if it's the upper GI, it's the lower GI, what part of the GI, it's the liver, the pancreas, which part of your system is involved. You should be able to narrow your history to these points by the end of your history taking. And then you should be able to know what is the disease process, whether it is an infection, whether it is an inflammation, whether it is a malignancy. So you should be able to sort out the disease process that is taking out in the system. You should be able to know which part of the system is involved. These should be the goals at the end of your history when you're especially when you're trying to make a diagnosis, if it's a diagnostic history. Okay, so the components that we will be discussing in history, and if you remember in my first session, I also spoke about this, that when you're given a piece of paper in the beginning, you should make a list of all these things. You should make categories, just like, subheadings of these points, and then you will just be filling in those. It's highly recommended. You don't walk in with a blank paper. Okay, so write out these points and just leave space 4 or 5 lines after each heading, and just quickly fill while you're taking history. Like, don't take notes on, like, complete statement, just points. You should not be taking notes the whole time, but you should not only be listening and not making notes at all. You should keep a balance. So it's better if you make a list of the questions that you're going to ask, and then at the end, just fill them up and make a very good summary. So of course, in the beginning, it will be your introduction. You'll say, you'll greet the parent. You'll say good afternoon, good evening. My name is Dr. Rabia. I am a part of the team and responsible for the treatment of your child. Am I speaking to mother of whatever the child's name is, mother of Sarah? And you do some rapport building, and then you go on with the history. Okay, so you make the company, the mother or the father, whoever it is, very comfortable. You greet them, you introduce yourself, you confirm your identity, and then you move on. So the first question that you ask, it will be a very general open-ended question. I believe that Sarah is here with some breathing problems. Can you elaborate this more? Let her speak. Okay, at this point, as I said, that you've made a list of the questions that you're going to ask, so just let her speak, let her tell you the story, don't interrupt her. So while she's telling you the story, just fill in the questions that you've already, like if she's telling you the onset, just write in the onset. If she's telling you the duration, just write in it. After you're finished with the whole story that she's spoken, then just go on with the questions that you're left with and that she has not answered yet. Okay, so in the chief complaints and the history of presenting illness, she will just tell you the story of how the child started to be sick, and what they did, what investigations. She may as well just tell you everything in that one go. So you don't have to interrupt her. Just fill in the subheadings that you've made for yourself and let her speak. Okay, this is a very important point. Okay, so after the chief complaints, like suppose the chief complaint is coughing. Okay, so at the side of the piece of paper that you have, just on the right top bottom, just make a list of differentials. If it's a cough, then make all the differentials that you can think of. So suppose if you think of infectious process, then write pneumonia. If you're thinking it's asthma, then write asthma. If you're thinking it's bronchiectasis, write bronchiectasis. Write all these differentials on this piece of paper in a top corner, and these will be your list of differentials, and these are the differentials that you will be ruling out in your further history, in the further questions that you're asking. Okay. Now, history of presenting illness. This we will break down in the further part of the session. Then the systemic review, which is very, very important. You cannot skip this. Then you know how much this disease is affecting the parents' perspective of the illness, what they think of it, how much it is treatable, what they have been told so far. Then if it is a chronic disease, like whether it's asthma, whether it's cystic fibrosis, then you go on with the complications of the disease, whatever the complications that you know of, like cystic fibrosis, go on with all the complications, the diabetes, the respiratory involvement, the GI involvement. Ask all those complications. Then go on, after the complications, go on with the investigations and the treatment offered for that illness. Okay. Then we have the past history, and this is a mnemonic I've made, which I'll explain later. All the other categories of the past history: the past, the development, the family, the birth, immunization, the nutrition, the drugs, the social. We'll all be breaking this down later on. Okay. So as I said, the chief complaints, just ask in chronological order. If there is what started first, cough, chest pain, the most important, the chief complaints you will come across in respiratory are these: cough, chest pain, breathlessness, exercise intolerance. Okay, so then we move on to the history of presenting illness. So I have made this mnemonic that I always and this is if you're following any mnemonic, it doesn't have to be this one. It is very important that you write that on the piece of paper that you're going in with. Does anyone have a question? Okay, so the mnemonics you have made for yourself, it is very important because you get very confused inside. So it's better that you write them on the paper that you're working in with. So you start with the onset. If it's a cough, when did it start? How did it start? Was it sudden? Was it over a period of time? The duration, the severity, how bad is it? Is it the whole day? Is it at some part of the day? The progression is very, very important. Is it getting worse? Is it improving, or is it the same? Then we have we also ask for the character. How is the cough? If it's like if it's pain, the chest pain, how is the chest pain? Is it more in moving? Is it more in breathing? Is it positional? Is it more during lying? Is it more during walking? So the character is very, very important. Then we have the aggravating symptoms, like if it is a case of asthma or any hyperactive airway, then we ask for the possible triggers. Like, we're not asking closed-ended questions, we're just asking, do you think anything triggers or anything aggravates this cough or whatever? Then we have the relieving factors. What causes the cough to relieve? Does the inhaler help? Does anything else help? Then we have the associated features. So in the associated features, you're doing two things. You're ruling out all the differentials. These are when you ask the set of questions. Like if the child presented with cough, then in the associated features, you're ruling out, so you'll ask if it is productive, you're ruling out bronchiectasis. If it is associated with wheezing, you're ruling out asthma. If it is associated with fever and chest pain, you're ruling out pneumonia. If it is associated with just like that. Okay, if it is associated with any other symptoms, you're ruling out the differentials at this point of time. This is very important. Then if in the associated features, you're also asking for, if for example we have a case of cystic fibrosis, like this can also be covered in the complications, but also you can ask the associated features of those illness at this point of time. Then we also ask the timing. If the cough more in the night? Is it more in the morning? Is it more after you take something specific? Is it more after exertion? So timing is very, very important. Then we move out to this we move on to the systemic review. You can just systemic review, you have to, it seems like it takes time, but it doesn't at all. You just say, okay, I'm going to ask you a set of questions to make sure Sarah doesn't have any of these. Okay, so in the general, you'll quickly ask any fever, any weight loss, let her respond to that, and just be, smooth, but at the same time try to be a bit quick. Any appetite loss in the cardiovascular system, you ask if there's any palpitation, any chest pain, any swelling in the feet. In the CNS, you at the same time ask for any seizures, any associated headaches. Then in the GI, if it's a cystic fibrosis case, you will come to know if there is any GI involvement, any renal, any endocrine involvement along with cystic fibrosis. So you will be asking these questions. Okay, so after the history of presenting illness, you've covered all the points in the chief complaints. Then you will go on to the to how this was processed, how this was addressed. So you'll start with investigations. What labs were performed? What tests were performed? Did they do a scan? Did they take some bloods? The parents will pretty much know the details. Then you will ask whether the child was taken into to ER for that purpose. So how was she managed? What did they do any nebulization? Did they do give any injection? Any antibiotics? So this will pretty much help you in how the patient was managed. And if it is a known case, then you're asking in the management, what are the teams involvement in the management? Like if it is a case of cystic fibrosis, at this point of time, you're asking whether there's an endocrinologist, gastroenterologist, or these specialties are involved in the treatment or not. What medications the patient is taking, any prophylactic medications, any nebulizations, and what is the emergency plan. So in the management, in this one go, it's better to get covered with all these 3 points: the multidisciplinary team involved, the medications that the child is taken, whether on a daily basis, any prophylaxis, any rescue management, and what is the emergency plan for that child. Okay, so then you move on with the complications. Like I said, you can ask this in the associated features back in the history of presenting illness, and here you can come to the complications, and then ask after every complication, ask how that complication is being treated. And then at the end of this, you will ask how about the activity of daily living. Is the patient able to manage her daily activities? Is she able to go to the restroom, or she needs any assessment because of the breathlessness? Just ask how the child, whether the child is able to play like her age fellows. Just this is a very, very important question. Okay, do we have any questions so far, or we can move on?
I have a question, ma'am.
Yes, please.
Yeah, I have seen some video clips that they are saying when you ask the patient, tell me what happened, then they start to keep on telling.
Oh yeah.
Will that be the scenario in role player, or we have to ask each everything, aggro defector, leave infector, everything we have to ask, or they will keep on telling the history?
Yes, a very good question. I already discussed that. Let her tell the story in the beginning. Okay, let her tell it. She will tell you how it started, what she did. So as I told you, if she is answering any of the relevant questions that you have in mind or you have made a list for, then you will just note them down. Okay, if she's leaving out any things, then you will just ask them in there. You don't have to cover like suppose if she's already told you how it started, well, it's more in the night, then you don't need to ask again, is it more in the night or in the morning. The answers that she questions, the questions that she answers, just consider them and then move on with the questions that she did not answer. Okay, I hope I answered your question.
Yeah, so the role play will be telling, isn't it?
Yes, role play, they mostly tell. Okay, some questions, some descriptions, they wait for you to ask. They've been told that. Yeah, so it's very important to ask those as well, but some they will just tell you. Okay.
Okay, okay, okay. Thank you.
All right. So then we move to the past history. This is up till now you've covered, like, for the presenting feature, that actually what the child presented with, you've covered all the aspects of that, if you've noticed. Okay, this was a very, smoothly, you've covered all the, you started from how it started, to ruling out all the differentials, to how it was investigated, how managed, any complications, then the effect of daily living. So up till now you've covered all the aspects of the complaints that the child actually presenting with. Now you're exploring other domains of the child, because we're not just taking the disease process, we're taking child as a whole, how he's living, how he's managing his illness, everything. So this is when we move to the past history. So I have another mnemonic. We'll discuss this just shortly. So we start with the past history, just briefly, any past medical or surgical history. And again, if this is a known case in the respiratory, it's mostly going to be if it's an acute case, it's going to be pneumonia, or any pleural effusion or anything like that. But that's mostly in the clinical examination. It's most probably going to be a pneumonia. And if it is a chronic case, then it will be a cystic fibrosis, or known case of asthma. So in that, the past history, you will start with, okay, how was Sarah diagnosed? How old was she? What did she have when she started? What did you do at that time? How was she what tests were performed? How did they start the treatment? So the past history for a known case will start like this, like just from the very beginning of the how it was diagnosed. This is actually a more systematic approach of how you take the history. You can also start with, if it's a known case of asthma, you can go in the beginning and start, okay, how did the asthma start? How was she investigated? But I personally, I prefer this one. I prefer that we start with the chief complaint. We cover all the aspects of the chief complaint, and then we go to the the known, whatever the known illness the child has. We move on to how she was diagnosed, when she was diagnosed, what features she had at that time, what was done. Okay, so these are the aspects of the past history. And if it is an acute case, just ask, does Sarah have any prior illnesses, any surgery performed? So this comes in the past history. Then we move on to the development. In the development, you can both ask an open-ended question. Can you describe her development for me? Do you think she is up to her peers, or just according to her age? You can ask a set of questions for each domain. Is Sarah able to, if she's say 2, is Sarah able to walk smoothly and run? And this will cover your gross. In the social, you can just ask, is Sarah able to play with kids of her age? Is she interactive? Is she playful? This will cover her social. Then in speech, you can say, is she able to you'll know what is the goal for that age. So you'll just ask, is Sarah, if she's 2 years old, you'll say, is Sarah able to speak in 2-word sentences? This is just how you can take the development history. Okay, so you can just swift on this one as well. Then in the family history, you can just say, can you describe your family for me, Mrs. ABC? How many siblings does she have? Any family illness of this of the same nature in your or in the husband's family? We can ask if the husband is related to the child's father, is related to the child's mother. We can ask these aspects in the family history. In the birth history, we can also ask an open-ended question like, can you describe her birth for me? Was it a smooth birth? Was she delivered on time? Any what is some event that you want to share regarding her birth? She will just be honest with you and tell you. If it is relevant, then you can go in the depth. If it is not, just ask an open-ended question and get done with it. We can ask for immunizations, but don't use the word either vaccine or immunization. Just say, well, has she taken her shots, or has she taken her jabs? Then in the nutrition, if it is relevant, if it is given in the opening statement that she is not appropriate, she's small for her age, or she's not a very well grown child, then you can ask them in the nutrition in detail. You can start with a 24-hour calorie counting as well. You can just start with what meals she has taken in the last 24 hours. Just to tell me about her breakfast. What did she have yesterday? If this is relevant, okay, what did she have after that? And just quickly, in your mind, just do some quick calorie counting, and then you can see if it was sufficient for the child or not. Then the social is important. If you think it is important, you can go in the detail or just ask how is her relationship with her siblings and with her parents. Okay, so these were the aspects of the past history. Then we have another mnemonic on further details. For for the financial, we can ask, okay, so what is the source of income for you at Sarah's father? Are you coping well? Are you satisfied with your finances? And then we ask about the impact of the illness. So the impact can be again subcategorized in impact, as in impact on the child, um, physical impact that we've already covered in the activity of daily living. So like how does she cope with her daily activities, and is she able to play, or does she get tired? Psychological impact, we can ask like that, and social impact. And on the family, of course, financial and social. You can start with saying like, I believe her illness must be financially straining for you, so are you able to cope up with it? And I believe her frequent visits to the ER, or her frequent hospital admissions have affected your social life. So can you do you want to talk about it? So we can address these questions like that. Okay, now that I mentioned, this is a very important a tip that I want to give you. This is actually a very you can say a negative impression if the mother is sharing, because the role player, they are trained to just um, share their worries just to see if you are empathetic with them, just because the examiner is just noting your reaction to those statements. Like if you're saying, so are you able to cope up, are you able to socially engage in with your friends or anything? And if she's saying, no, I'm very much affected, I'm exhausted all the time, it's either work or her illness, and then you just don't move on to the next question, like, okay, well, tell me about her schooling. You have to be very empathetic. Oh, I'm really, really sorry for that. At the end of this, I'll talk to the we will try to do something to for the social services to involve and give some extra care for you regarding this problem. So you have to show empathy on any worry that she expresses. Just don't move on. So S is for both support and schooling. So in the support, you go on with any if it is a chronic illness, any financial support, any allowances she's getting, any asthma allowance or any other allowance that she's getting for her illness. The social support, in this comes the social welfare, the respite care. For chronic illnesses like these, there is respite care in which these healthcare involvement is made, and they just take care of the child while the parents can have it can have some time to themselves. They can involve in some social activities while the social care services are taking care of the child. So ask if she is being provided with any of these, or whether she needs any of these. Then come with the schooling. Does she go to a mainstream schooling, or does she have any special educational needs, or have they been addressed? And if it is again a chronic illness, then we ask for any home modification done according to the needs. These are again, they're only relevant if you find them relevant. I mean, if you're coming across with a case of pneumonia, you won't ask if any home modification has been done. Just ask her about her housing. Do you think you have a well ventilated house? Like, you just in that category, you ask the relevant question. I hope I'm being clear in this point, that you ask the question relevant in that category. If it is a case of tuberculosis, you ask whether she lives in a very congested community, or anything of that sort. Okay, so I hope I'm clear until this point. If there are any questions, I'm happy to address them. Okay, so after this, you will be closing your history. So just ask Mrs. ABC, are there any concerns that I haven't addressed yet? I haven't addressed that. yet. And then just say thank you very much for speaking with me. Thank you very much for your time. I've taken the important notes, and I will get back to you after discussing with my team. And thank her for her time, and offer her some sympathy if that is needed. Okay. So the examiner has already listened to all this history taking process. So the next step, and a very important step, is how you are very well able to summarize your history in a very crisp manner. So I always say, you guys already know this, the history and examination, it's all a skill. The more you practice, the more you will be very, very smooth in it, the more you will be able to enjoy. The first few times it's going to be difficult. You take history, take in detail, see what points you missed, try to take it again, and then set a timer, try to manage in that time, and then always summarize it for you, record it, and then listen to it. See how you sound, see how much clear you are. Okay, so summarization is again a very important step. So if it is a known, I've just written a history, just supposing it's an asthmatic patient, a mild intermittent one, and who has come. I'm sorry, are there any questions? Okay. So if you're dealing with an asthmatic child who has just come with a mild exacerbation, so this is how you can go on with it. ABC, a 3-year-old lovely child, non-asthmatic, has come to us today with worsening of shortness of breath. This is in background of a recent shift to a new area. I'm sorry for the misprinting, where there is possible exposure to trigger possibly pollen. I mean, if she's moving on to a different area, she basically fits in the mild intermittent category, requiring Ventolin inhaler PRN only, and the current episode was rated as mild exacerbation. She's otherwise a healthy child. Now you're coming to the child as a whole. You've concerned her illness until this point, then you say she's otherwise a healthy child with no social or financial issues, and the illness has minimal effect on her daily life, and this is how you go on with it. Okay, so this brings it to the end of the history station. If there are any questions, we can go on with them. I'll take a 2 minutes break.
Hmm.
Okay, can we move on to the examination station now? Okay, so I will just encourage anybody who can just summarize how they will approach a clinical examination center for respiratory, and then we can discuss whoever is closest to their exam. They can they can summarize how they will approach the respiratory examination center, and then we can discuss the points if anybody is happy to do that. Do we have any volunteers?
Yeah, I'm happy to go.
All right, that's awesome. Please.
Okay. So should I start?
Yes, please start.
Okay, so okay. So when I get into the room, I would introduce myself. I'm Dr. Stephanie. I'm one of the children doctors. I would like to examine your child. I will verify the relationship between the parent and the child, and I'll wash my hands. and I would look around for any devices of daily living. I would see if there's any inhaler, any sputum port, any peak flow meter, if there is any what else again? Okay, that's all. Then I would look at the child, check for the 4Ds, if there's any dysmorphic features, if there's any if the child is dysnic. I want to look at the dimensions. Is the child small for age? Is the child acutely ill looking? Is the child in any respiratory distress? Then I would yeah, then depending on the age of the child, I'll offer a chaperone. Then I would ask to examine the hands of the child. So examining the hands, I would I'm looking out for finger clubbing, for sinuses, for palmar erythema. Then from the hands, I'm looking at the skin. Is there any eczema, any skin rash? Then from the hands, I want to check the pulse. I want to check the blood pressure. Then I ask the child to open the mouth. I'm looking out for sinuses. I'm looking out for pallor. Then I would also look into the nose and look into the ears and pull down the eyes and look into the eyes, looking for pallor and sinuses. Then I would ask the child to expose to remove the shirt, the shirt. I want to see the child is in any obvious respiratory distress. Is there any work of breathing? I'm looking at the chest. I'm looking for asymmetry. If there's any symmetry, if there's any chest deformity, if there's any if there's any scars, looking at the front and the back. Then I'm looking for any skin changes. Then I start my examinations. I ask the child is in pain. Child is not in pain, so I want to check for expansion. Okay, I'll palpate for chest tenderness first. Then I'll check for expansion. After checking for tracheal centrality, depending on the age of the child. If the child is less than 2, I may not check for tracheal because it's short neck. But if it's more than 2 years, I'll check for tracheal centrality. Then I will check for expansion. I also palpate for the apex beats. Then I'll check for vocal resonance, say 99 on all the anterior and posteriorly. Then I would also check for percussion. I'll percuss the lung zones, upper, mid, and lower zones anteriorly and posteriorly. Then I would also listen. I will listen for breath sounds. So I will be looking out for if the type of breath sounds, vesicular or bronchial, if there are any added sounds, if there are any crackles, wheeze, bronchi. Then I would listen to the lung bases. Then I would complete my examination by palpating the abdomen, looking out for hepatomegaly, and also checking the foot for pedal edema. And I'll tell the examiner that I would love to plot the weight and height on an appropriate good chart. Yeah.
Okay, that was just perfect and just in time. Yeah, that was a very, very good presentation. Big applause to you. Okay. Did you just asking? Did you cover the back examination as well?
Yes. So I would do them. I would do the front and back at the same time because I wouldn't want to be doing front and forget to do it. So if I do, I would like to do it at the same time.
It's very important and not to be missed. Okay, perfect. We'll just go on with it now. Okay, so as she very well said, you start with greeting the child, introducing yourself. You ask if you can have a look at their chest, and after their consent, go on, wash your hands, approach the child from the right, and then do the necessary exposure. Better to do it in the beginning, so you can have a look at the child as a whole, rather than when you move on to the chest and then asking them to expose. Okay, so better to get done with these things in the beginning. Then in whether doesn't matter which system is involved, the most important part of the examination is those 15, 20, 30 seconds that you give to the general survey. Just don't, if there is a GI examination, just don't jump to the abdominal examination and without looking at the child or the surrounding as a whole. This is very important. There are a lot of points or cues that you will not be able to pick when you're closing to the child, but when you're just having just a look at from the observing just from a distance, without touching, without doing anything, just have a look, and many dysmorphic features will be visible at this point of time. Just have a look at the surrounding and the child as a whole. This will clarify many points. Maybe you will not pick you'll get confused regarding the tachypnea, but when you're having a look from a distance, you'll feel that the child is not breathing comfortably. So there are a lot of points that will be evident to you after you give these 15 seconds to the general survey. Just relax, just have a look at the child. Many things will be clarified. This will save you a lot of stress if you just rather than you just moving to the examination and just grabbing the child's hand and starting with nail examination. Don't ever do that. This gives a very good impression. Just stand back, look at the child, look at the surrounding, and don't care about the time. Your examination will definitely finish on time. Don't care about these 15 seconds. Just take them out of your examination and have this general survey of the child. Okay, all right. Okay, so in the surroundings, of course, as she very well mentioned, you'll look for any nebulizers, any inhalers, any pancreatic enzymes, those medicines lying at the side, any other medications, any oxygen concentrator, a sputum pot on the floor, any monitoring devices, anything like that. This is in relevance to the respiratory. In the patient, you're looking for dysmorphic features relevant to the respiratory, of course, receding chin and any sutured or repaired cleft lip, because that may be associated with a cleft palate. And then you see if the child is a poorly nourished or a well-nourished child, whether or not he or she is distressed, whether or not he or she is well perfused, pink in air, cyanosed, on any oxygen support, whether or this is also an important thing that you will only find while you're having a general survey, not while you're close to the child. See if it's an alert child or a drowsy child. Notice for any coughing or any noisy breathing at this point in time. Okay, just give me 1 minute, please. Okay, sorry for that. So in the general survey, you're just observing these things. Then moving on, and you're looking at the child as a whole, from the foot and from the side. This you can do after your examination from the hands and fingers. I prefer to do it just at that point of time. You stand at the foot end of the child while you have already exposed the child. and the chest asymmetry, the respiratory rate, the shape abnormalities, these will all be evident if you're looking at the child from the foot end, the chest expansion, all of these features. So count the respiratory rate at this point of time, do it in 15 or 10 seconds, and then multiply to make it as per minute. Look for any asymmetry, look for any chest shape abnormalities, excavatum, carinatum, any Harrison sulci, look for any scars if they're evident from the foot end, and for any central venous accesses. They may be hidden, so it's very important to pay attention to them if you've well exposed the child. Then you come from the profile view or from the side end, from the side. In this, you will look at the anteroposterior diameter. If it looks like a barrel chest, how is the breathing pattern while the child is just lying down? Is it abdominothoracic or is it thoraco-abdomen? At this point of time, don't miss the lateral aspects of the chest for scars. Lift both hands of the child, and actually examination is more of a pretend as well. So you're just lifting both those hands, just looking at the armpit areas, lower down, to see any scars on the opposite side as well. It's very, very important to observe for this. Then we move on from the hands. So move on to the hands. So in the hands, I would prefer that rather starting with one hand and then doing the other hands, it's better. It's even more comfortable. You ask the child to hold out both his hands. You have a look at them simultaneously. You look for any clubbing, look for any pulmonary erythema, any cyanosis. Just hold those hands, turn them around, ask them to demonstrate for clubbing. Look for pulmonary erythema, palpate the pulse on both sides. So if you're turning the child a bit towards yourself and then asking them to show you both hands, so it's more convenient, it's more comfortable. You're not able to you save time rather than from moving from one hand and then the other. So do both the hands examination simultaneously. Look for cyanosis, any clubbing, pulmonary erythema, the pulse for rate, volume, character, and rhythm. These are very important because there are some associations of respiratory in which there is heart failure. So what is the term used for that? If there is right-sided heart failure associated with any lung issues, can anybody tell me?
Core pulmonary.
Yes,
Core pulmonary, madam.
yeah. Okay. So what else is important for the pulse? If you're examining the pulse, what else is important? Can anybody explain pulsus paroxysmus? Okay, so what are the cause of pulsus paradoxical, and what are the how does it demonstrate? So in any features in which there is compression from the heart from either the lungs or the pericardium itself, like say it's a tension pneumothorax, say it's a cardiac tamponade, any compression of the heart from the surrounding structures. So it of course involves the respiratory system. You palpate the pulse and you just assess it while with the breathing pattern of the child. So what is the normal pulse change with the breathing pattern? If you see, you see an ECG and there are periods of increased heart rate and decreased heart rate. So we say no, it's just sinus rhythm. So what do you mean by sinus rhythm, and why is it increased heart rate at some point and decreased heart rate at some point? How is it related with the breathing cycle? Can anybody tell me? Okay, so there's a mnemonic I would ask you guys to remember. It's very helpful. Just remember, with inspiration, remember increase. So with inspiration, there is increase in heart rate. Okay. So increase in heart rate, but actually and with expiration, remember decrease. So with inspiration, if you remember increase, of course with expiration it is decreased. So with inspiration, the heart rate will be a bit fast, and with expiration, the heart rate will be a bit slow. This is normal sinus rhythm. Pulsus paradoxicus is the opposite. So if there is compression of the chest by the surrounding structures, in the inspiration, the heart rate will be decreased, and in the expiration, the heart rate would be increased. So this is also, it's not very obvious and very demonstrated, but this is something that of course you need to know. So in the hands examination, you move on to the wrist examination for any joint swelling associated with cystic fibrosis. Then you move on to the, you're just generally scanning from the fingers to the palms to the pulse to the arms, see for any eczema, any scratch marks associated with any hyperactive airway. You see for a BCG scar. You can just get done with the both axillary lymph nodes at this point of time. Okay, so it's like it's more smooth in this way. You can leave the face and neck in the end, and you can move to the chest, or you can just have a general survey of face at this time as well. See for any central cyanosis, any Cushingoid facies associated with the asthma, steroid treatment, oral thrush. And you can examine neck for the cervical lymph nodes as well as this point of time. So you've very smoothly moved on from the hands to the axillary lymph nodes to the neck, and then you can move to the chest. So the inspection you've already done. This is why I recommend it in the beginning, so that you've had a general inspection of the chest, so you're a bit clear on what you're dealing with. Okay, if it is a barrel chest with an increased AP diameter, you're more sure that it's probably a case of asthma. If he has scars, you're more sure that it's some post-operative case, maybe anything. So the inspection part you've already done. Now you've moved to the palpation. In the palpation, then the helpful mnemonic is fate. So there are four aspects in the palpation that you should cover. Okay, so start with, you can go with any sequence that you want. FATE. So the F stands for the tactile fremitus, A for the apex beat, T for the trachea, and E for expansion. Okay, so you can start with expansion. Can anybody tell me how you do the chest expansion?
Ma'am, we put both the hands for the front of the chest to see for the expansion, and we can encircle the both the hands around the chest and see the distance, how deviation from the mid-sternal line.
Yes, perfect. So when you're positioning your arm with your, yeah.
And for the
Please
back, just put on the scapular region and again see the distance of the thumb from the midline.
Yes. Just one thing important for this chest expansion is that when you are encircling your hands around the chest, you make sure all your fingers are wide apart, just fanned out. They're in the intercostal spaces or the ribs, whatever, but they are fanned out, and the thumbs should not be touching each other. They should not be overlapping. Okay, so there should be some distance in the thumbs, and then you can, in the expansion, it is important that you ask the child to breathe deeply. In some steps you don't ask them, but in the chest, when you're just looking for chest expansion, you have to ask the child to breathe deeply, and see if the thumbs are equally moving apart. Okay, if the one thumb is moving more and the other is moving less, then we can say that there is collapse or any consolidation or anything that abnormal on the abnormal side. Is that clear? Okay, so for the palpation and the auscultation and the percussion, it is very important how many domains did we divide the chest into for the purpose of examination. Always divide them in 3 quadrants. Okay, so just imaginary, just draw 2 lines and you have 3 quadrants of the chest. So you're doing every examination in each quadrant. The first should be at least 2 ribs, and then the second to 4 ribs should be your second quadrant, and the 4th to 6th rib should be your third quadrant. So you're doing your percussion in all of these quadrants, both anteriorly, laterally, and posteriorly. Don't ever miss the lateral portions as well. So you're doing percussion, auscultation, the fremitus, the expansion, all of these you're doing in all the 3 domains. Expansion you can just do once, but the rest you have to do in all of these domains. Okay, the quadrants. Yes, so that was the expansion. Then you move to the apex beat. For the apex beat, it is important that you put both your palms on each side of the sternum. Okay, because why? There could be what? Dextrocardia.
Dextrocardia.
Okay. So don't just waste your time on the palpation on the right side and you get confused. I cannot palpate any apex beat because dextrocardia, it's a very common case in the respiratory system. So put both your arms gently on both the side of the sternum and see for the apex beat, and then try to locate it with your fingers and then count from the sternal angle to how far it is, whether it's in the mid-clavicular line, and then from the sternal angle, which is which space? The sternal angle, if you move laterally?
Second intercostal space.
Second intercostal space,
Yes. So from the second intercostal space, you come down and see where the apex beat is located. Then you see for the apex beat whether the character is normal, whether it is heaving, taping, or just normal apex beat character. Okay. Then for teeth, the tracheal position, you ask the child, you can cover this as long as you know that you won't miss it. You can cover this even in the neck examination. But it's important to explain to the child that I'm going to just, feel your neck. It's going to feel a bit funny, but don't worry about it. It's going to be super quick. Okay. So if you're doing any step, this is very common in the respiratory system actually, that you will find that the child maybe get uncomfortable. So it's very, very important to explain them along that it's going to feel a bit funny, it's going to feel a bit so, don't worry, it'll be super quick, just let me know if you feel pain. Okay. So in the tracheal tug, can anybody tell me how the tracheal position is, not the tracheal tug, how we go on with the tracheal position? What's the technique for that?
Using our two fingers. We palpate the trachea in the center.
Yes.
So usually it is slightly deviated towards the right.
Yes. So yes, it can be both 2 fingers, it can be 3 finger. In the 3 finger method, you can put your middle fingers gently on the trachea, not pressing on it, and the index finger and the ring finger, you're sort of seeing if the space on both sides of the trachea is equal. Okay. Then you go for the tactile fremitus. As I said, you've already divided the chest in 3 quadrants. So you will only you will place your palms on each quadrant anteriorly, both sides simultaneously. Ask the child to say 1, 2, 3. See if you feel the vibration equally on both sides. This is just, this may not be very conclusive in your examination, but it's just an important step that you need to do. You'll be more, the more conclusive steps are percussion and auscultation, of course. So the tactile fremitus, in the one important thing is while you're examining the front of the chest, do the front and the lateral chest. Okay, so that you're only left with the back, because you may forget it in the back. While you're doing the front examination, do the tactile fremitus or the percussion all on the anterior aspect first, 2 to 3 quadrants, and then 2 in the lateral. In the lateral chest walls, there is no 3 quadrants because there is the arm area. So just two percussion notes in the lateral area, 2 tactile fremitus demonstration in the lateral area, and 2 auscultations in the lateral area. Okay. And we move to the percussion. Percussion, as I said, just take all the 3 quadrants, but it is important that you're doing on the contralateral side at the same time. Like if you're tapping the upper right quadrant, then go on and tap the upper left quadrant first for comparison. Don't come down. Okay. Then do the upper to the middle right quadrant and the middle left quadrant, then the lower right quadrant, then the lower left quadrant. Okay. Yes, and one important thing is make sure that the hand you're tapping with should not be touching the chest wall. Just the finger that you're tapping, the middle finger that you're placing in the space, and it's important to place your finger in the intercostal space. So just tap it gently and make sure that the rest of your hand and the other hand is off the chest. Okay, if a little of those other fingers are touching, it's okay, but make sure that there's minimal contact between any other part of your hands. Just the finger that you're tapping, that should be just very firmly pressed in the intercostal space, and then you'll get a very good note. You'll feel whether it is dull or hyper resonant. Okay. Then we move on to the auscultation. It's important in the auscultation that don't just be, moving, putting steth on one side and then the other. It's very important to show to the examiner that I'm actually listening for the breathing cycle. So it is important that in each quadrant, you are listening from the inspiration and the expiration, then move to the opposite side, then move down and to the opposite side. But in each auscultation, don't pick the stethoscope up before you hear the whole inspiration and expiration cycle. Okay, so only then you will able to tell if it is a bronchial breathing, if it is the inspiration cycle is short, the expiration is long. How will you be able to tell? So it's very important to finish the whole breathing cycle in each auscultation quadrant, and then go on with the lateral to on the lateral wall, do it at one side, then the opposite side, then one down, and then on the opposite side one down. So while you're examining the front of the child, it is better to just finish up with the palpation. This is what I recommend, because it may be missed out later. So just quickly do the liver palpation. You don't have to do the whole formal way of doing it. Just go from the right lower quadrant, just move up while breathing, and just rule out any hepatomegaly, and quickly go for diagonally for the spleen, and then ask the child to sit straight. After you ask the child to sit straight, do all the steps of the examination from the back again: the inspection, the palpation, the percussion, the auscultation, and then yes, this is just summed up. If you've missed the face examination, you can do this now. You can do, if you've missed the cervical lymph node examination while you're examining the child from the back, you can do this right now, because this is a more comfortable way for doing the cervical node examination anyway. Just ask the child to flex the neck a bit to loosen the muscles, and then very gently in circular motion start from the submandibular, submental, and then lower down the supraclavicular areas, the preauricular, the postauricular areas. Just do the palpation. If you have missed the throat examination, you can just do it right now at this point of time. Even if you miss anything, you can say that I would like to end with the complete ENT examination, the ear, nose, and because I don't, of course you cannot manage time for doing that. You will ask for the child's growth parameters, and you'll offer to plot them. And if the child is a known case of asthma, or if you feel, then you'll offer to check for the peak flow, and finish off with the of course the ENT examination. Okay. So some of the examination findings that you will see for different examination scenarios: for consolidation, pleural effusion, a lobar collapse, a pneumothorax, and any pleural thickening. So for consolidation, what are the features on inspection? The chest wall movement will be decreased on that side. So what are the features for percussion for consolidation? Can anybody tell me?
Slight, basically that is not a absolutely stenoidal, but slight dull note is there.
Yes, slightly dull note. What is important for the consolidation? Which step?
Then whenever we auscultate, then there is a bronchial breathing.
Okay, so how many of you cannot, not clear of how you can tell about bronchial breathing is?
Basically, okay. Whenever we think of the bronchial breathing, then we think that there is a air passing in a hollow.
Yes.
Means some things.
Exactly. So bronchial breathing, I mean, theoretically, it is of course that the inspiration expiration cycle are equal, but nobody can pick these things up. If you want to know what bronchial breathing actually,
you can hear it over the trachea.
Sounds like, yes, it's as though you're not auscultating the chest. It's as though the child is breathing through a hollow pipe directly into your ears. It's going to sound very different from the usual auscultation, how you feel it, because you will not feel like it's coming from the chest. You'll feel like the child is directly breathing into a pipe into your ears. So that is actually what bronchial breathing sounds like. Okay. Then moving to the pleural effusion, what is the important step for a pleural effusion? Starting with the inspection, of course, decreased expansion on that side. What is on, how will it be on percussion and palpation?
Percussion is there is a dull note, and when we auscultate, then there is a decreased air entry on that side.
Yes, decreased air entry. Okay, so what about lobar collapse?
Ma'am, everything will be decreased and trachea will be pulled towards the side of the collapse.
Yes, exactly. Okay, so this is how it's going to be. What about pneumothorax?
In the pneumothorax, there is a hyperresonance basically, and whenever we palpate the trachea is going to the opposite side.
Yes. And how is the percussion?
Percussion is a hyperresonance.
Hyperresonant. How are the breath sounds?
Breath sound is
ma'am.
decreased on the in the pneumothorax side.
Okay, okay, perfect. This brings us to the end of the examination. We're just 1 hour, we're done with that. So do you guys have any further questions? I'm happy to answer. Otherwise, you can just, our whole panel will answer if you can just ask in the WhatsApp group, the Facebook group, and the Telegram. So it was very, very nice talking to all of you. I hope you got some benefit from the session, and we can close the meeting now. Yes, Dr. Naresh, please.
Yeah, ma'am. Basically, what type of the cases is coming to the respiratory? Means there's a cystic fibrosis because
Yes.
we are giving in India from that there is a less chances of the cystic fibrosis, more
Yes.
chances of the bronchiectasis.
So actually, yes, cystic fibrosis is actually one of the if you find bronchiectasis, cystic fibrosis does not have any other, the respiratory demonstration of the cystic fibrosis is actually bronchiectasis. So if there is bronchiectasis and the absence of any other cystic fibrosis features, then you can just say bronchiectasis. Cystic fibrosis is just a cause of it. Okay, so it can be bronchiectasis, it can be in the Middle East, it can be a case of tuberculosis, it can be a case of pleural effusion, it can be a case of pneumonia, it can be any rare syndromes. If they come across, they'll definitely put in the exam a Carter syndrome with dextrocardia and bronchiectasis. So these are the cases that it can be an asthma patient. Any of these can come in the clinical examination.
And ma'am, when we call it chronic suppurative lung disease, it is same as bronchiectasis?
Yes, it's one of the cause of bronchiectasis.
Okay,
because
yeah.
in India, ma'am, there are 65 means cystic fibrosis people are not seeing.
Yes.
So that's why the bronchiectasis and the basically tuberculosis is very common.
Exactly.
And pleural effusion is very common. Collapse is very common. Empyema is very common.
It can also be
But this time they give.
yes, it can be a case in which
But
the
this time they give in the
examination is completely normal and you will just see a scar of a chest drain recently placed. So it's actually a post pleural effusion in which the chest drain has been placed. This can come. So you should be very, very careful about these scars. You will just find a scar in the fourth intercostal space which will be very hidden in the armpit area. This is why I emphasize that always examine the lateral examination. And since the pleural effusion, it has been drained, so the rest of the examination is going to be completely normal, but just a scar of the drain. So you have to be very vigilant in these things.
For one question more, ma'am, in Pakistan from the last 3 days back, one respiratory case was coming, in which there is no finding and only the child is having the squint.
Only the child is, sorry, what?
Having the squint.
Okay. And that was
the candidate. Respiratory. The candidate is written. There is a respiratory case, and I didn't find anything, and only the squint.
It could be, if it's not a squint, it could be Horner syndrome associated with any pulmonary pathology in the form that it's obstructing the spine. But we'll definitely look into what that case was and we'll definitely share. So keep yourself posted in the group. We'll give some feedback regarding that, because sometimes, the candidates, they say the examination was completely normal, but sometimes they're missing out. Or so when we get more feedback from that station, we'll be able to be more clear on what that station actually was. But eye examination, it is only relevant in the respiratory system if it is associated with some some masses in the upper chest, so they are impinging on the sympathetic chain, so that can cause Horner syndrome. But squint, I'm not sure of. So once we get more feedback from that station, we'll be able to be clear on what that actually was.
Thank you, ma'am. Thank you very much.
Thank you so much. Thank you, guys. Have a lovely evening. If there are no more questions, we can just end this meeting. Thank you for your time.
Thank you.
Thank you, ma'am.